Hi, I'm Dr. Tom Kravis, Physician Executive for 3M Consulting Services. Thank you for joining me. Today we're going to talk about ICD-10 documentation for gastroenterology and gastrointestinal surgery. There are some changes you will need to make in your documentation to support ICD-10, but there are instances of documentation that can remain the same. Let's get started. We will review this information today so you'll have time to fully digest it before the transition to ICD-10. I know you are busy in your clinical practice, so I will briefly summarize the key takeaways. In your documentation of patient care, consider the use of adjectives. Link the cause and effect of each condition. Be specific about aspects of a disease and each anatomical site, and use exact dates when appropriate. A little more on each of these. Differentiate in your notes whether or not a condition is acute, chronic, or acute on chronic whenever appropriate. For example, document acute gastrojejunal ulcer instead of just gastrojejunal ulcer. Use due to or secondary to indicate cause and effect, and to record all conditions the patient may have, such as acute gastrojejunal ulcer due to or secondary to alcohol dependence. Think about the most current terminology to describe a condition or different aspects of the disease. For example, third degree or stage 3 hemorrhoids. Precisely designate anatomical sites. For example, document the anatomical site of an ulcer rather than just peptic ulcer. Use exact dates when appropriate. For example, when a patient is admitted for acute myocardial infarction and the patient previously had a recent MI, document the exact date of the recent MI. Ask yourself, what else could I add in my notes about this patient's condition that would better communicate how sick the patient is, which in turn better communicates the resources needed for patient care? Incorporating these aspects into your documentation will result in an accurate picture of your patient's severity of illness and risk of mortality. This in turn will result in accurate public reporting on quality and outcomes. And it will help reduce the number of queries you receive to clarify your documentation. In the upcoming slides, we'll take a look at some diseases and procedures that have new documentation requirements under ICD-10. Investigators performing epidemiologic studies often rely on ICD codes and databases to identify cases of a specific illness or condition. Because the ICD-9 code for Barrett's esophagus also classified ulcer of the esophagus, identifying cases of Barrett's esophagus required review of individual medical records. ICD-10 now classifies Barrett's esophagus separately from ulcer of the esophagus and provides increased specificity and the requirement to identify with and without dysplasia. If you know the patient has associated dysplasia and whether it is low or high grade, document this in your notes. The coder is not permitted to assign the code based only on a path report. Codes are based on what you document. There's not much new here. For all types of hernias, continue to document anatomical site with or without obstruction and with or without gangrene. For inguinal hernias, specify right, left, or bilateral. For inguinal and femoral hernias, specify if recurrent. Once again, there's not much new here. Like ICD-9, ICD-10 can classify gastroenteritis due to a variety of causes or organisms when documented. Specify the etiology and/or organism when known or suspected. Diagnoses such as gastroenteritis due to norovirus or suspected viral gastroenteritis convey more meaningful information than a diagnosis of gastroenteritis or a list of symptoms such as nausea, vomiting, and diarrhea. Document as much as you know or suspect about the gastroenteritis at the time of your evaluation. ICD-10 uses the term hepatic failure instead of hepatic encephalopathy. Additionally, ICD-10 provides for the ability to distinguish between acute or subacute and chronic hepatic failure, and with or without coma, which when documented will allow the reporting of how sick your patient is. Additionally, codes are provided for hepatic failure due to drugs, which you are encouraged to specify. It has been my experience that physicians often document the signs and symptoms of hepatic failure, for example, confusion, altered levels of consciousness, or coma, without actually documenting the underlying condition itself. So if your intended or suspected diagnosis is hepatic failure or hepatic encephalopathy, that is what you should document in your notes. But you also need to specify whether it is acute or chronic, with or without coma, and specify the etiology of hepatic failure, such as alcohol dependence. Obviously, it's appropriate to include the signs and symptoms in your notes, as long as you also include the diagnostic terms of hepatic failure or hepatic encephalopathy. ICD-10 provides several new codes for specific types of pancreatitis, such as idiopathic acute pancreatitis and alcohol-induced acute pancreatitis, while continuing to distinguish between acute and chronic, as was in the case of ICD-9. However, there are continuing opportunities for improvement in the documentation of acute versus chronic pancreatitis and the specific etiology. Let's take a look at some actual medical record documentation on the next slide. We see here in this example of medical record documentation a final diagnosis of pancreatitis and alcohol abuse. There is no statement of acute versus chronic, and there is no linkage between the pancreatitis and alcohol abuse. The final diagnosis on the right tells a better story. It clearly states the pancreatitis is acute and shows cause and effect by stating due to alcohol dependence, which results in the reporting of alcohol-induced acute pancreatitis. The coder is not permitted to assume the alcohol caused the pancreatitis. Only you are able to document and use words such as caused by, due to, or secondary to. Additionally, consider the statement in the history, daily alcohol use. If your intended diagnosis is alcohol dependence, state dependence rather than abuse or use. Dependence and use or abuse are two different codes. ICD-10 provides a single combination code to report Crohn's disease and any associated complications such as rectal bleeding, intestinal obstruction, fistula, or abscess. Be clear in your notes concerning associated complications so that an accurate picture is conveyed of how sick your patient is. Just as in ICD-9, anatomical site is classified as large or small intestine or both. Don't use the term inflammatory bowel disease when your intended diagnosis is Crohn's disease. A diagnosis of inflammatory bowel disease results in the reporting of a code that simply says unspecified non-infectious gastroenteritis and colitis. And this may understate the severity of illness and risk of mortality of your patient. As was the case for Crohn's disease, ICD-10 provides a single combination code to report ulcerative colitis and any associated complication. Again, be clear in your notes concerning associated complications so that you tell the story of the patient's severity of illness. ICD-10 classifies anatomical site for ulcerative colitis as pancolitis, proctitis, and rectosigmoiditis. A diagnosis of ulcerative ileocolitis is coded as ulcerative pancolitis. Just be as specific as you can about the anatomical site, and the coder will take care of the rest. Don't use the term inflammatory bowel disease when your intended diagnosis is ulcerative colitis. A diagnosis of inflammatory bowel disease results in the reporting of a code that simply says unspecified, non-infectious gastroenteritis and colitis. Once again, this may understate the severity of illness and risk of mortality. Current medical literature classifies hemorrhoids into 4 stages or degrees. The distinction among these stages is clear and affects the therapy given. Consequently, ICD-10 has included this new terminology and defines the stages as you see on the screen with the associated codes. Note that bleeding when present is included in the code for each grade or stage of hemorrhoid. However, the source of the bleeding should be clearly documented in your notes as due to hemorrhoids or due to some other problem. You should no longer use the term internal or external in your patient care notes. You should describe the stage or grade instead. Another code is assigned for perianal venous thrombosis when you document thrombosed hemorrhoid in addition to the grade or stage. ICD-10 has greater specificity for anatomical site and usually requires documentation of laterality for paired organs. Be sure your documentation is as specific as possible when identifying anatomic site. Unchanged from ICD-9 is the classification of malignancies as primary or secondary, which is a particularly problematic area of documentation for coders. Often, primary or secondary is not specified, and in the case of secondary malignancies, whether the primary site is still present. A statement of history of can be ambiguous and may prompt a query. For example, appropriate documentation of a malignancy would be metastatic cancer to liver from colon. Patient underwent colon resection 1 year ago and there is no evidence of recurrence in the colon. This documentation clearly identifies the primary and secondary sites and states the primary site is no longer present, all of which are factors considered in code assignment. Malnutrition is an underdocumented condition in the elderly. However, it is also an important indicator of your patient's severity of illness and an important influence on performance metrics such as readmission rates, length of stay, and quality outcomes. If your patient has malnutrition, you should document the clinical picture, the type, such as protein calorie or protein energy malnutrition, and the stage or degree. For example, mild, moderate, or severe, or first, second, and third degree. Your notes should include clinical findings such as patient with terminal cancer, 20-pound weight loss, and cachexia, and any supporting labs such as low albumin. Given the health risks of obesity and the number of obese people, it is important for us to be able to continue to track the prevalence and cause of obesity among U.S. adults and children. Since overeating is the #1 cause of obesity, it should come as no surprise that ICD-10 has a new code for nutritional obesity or obesity due to excess calories. So consider incorporating nutritional obesity into your vocabulary when applicable. It's a few less words than obesity due to excess calories. If your patient has morbid obesity, also document if alveolar hypoventilation is present. ICD-10 has a single combination code for this. As in ICD-9, ICD-10 continues to classify obesity due to other causes, such as due to drugs or endocrine disorders. As physicians are increasingly held accountable for patient outcomes, a huge concern is how to classify the patient who fails to follow a recommended regimen of care and gets sicker as a result. Under ICD-9, there is only one generic code for such a patient that says non-compliance, and no additional detail as to why the patient didn't follow your instructions. But in ICD-10, there are several codes to describe why a patient is non-compliant in taking drugs prescribed by you. This new clinical terminology is drug underdosing. Underdosing identifies a situation in which your patient has taken less of a medication than prescribed by you, either unintentionally or intentionally. Document in your notes why the patient isn't taking the correct amount or frequency of their medication and the associated condition. For example, patient was admitted due to flare of her Crohn's disease. Patient has age-related dementia and forgot to take her sulfasalazine as prescribed. Or, patient cut her dose in half this month because of financial issues. ICD-9 provided a single code for tobacco abuse and dependence without differentiation and without further specificity for the type of tobacco product. ICD-10 provides separate codes for these. If your intended diagnosis is dependence, dependence is what you should document rather than abuse. According to the Centers for Disease Control and Prevention, most smokers are dependent, and nicotine dependence is the most common form of dependence in the U.S. Additionally, further specificity is provided in ICD-10 for the type of tobacco product dependence, as cigarettes, chewing tobacco, or other, for example, cigars, so this should be documented as well. Your documentation should differentiate between current abuse or dependence versus a person who no longer uses tobacco. Starting in 2002, the number of former smokers has exceeded the number of current smokers. For tobacco dependence, ICD-10 provides the ability to report remission and withdrawal. Examples of nicotine withdrawal symptoms include irritability, anxiety, difficulty concentrating, and increased appetite. ICD-10 also provides the ability to show a cause and effect relationship between tobacco dependence and nicotine-induced disorders when documented. Finally, your notes for a patient's exposure to secondhand smoke can be converted to an ICD-10 code that says exactly that. In ICD-9, codes for complications did not identify when the complication occurred, the body system affected, or type of surgery performed. ICD-10 codes do. In order to code a complication, the coder must know whether the complication occurred intraoperatively or postoperatively, so include these details in your notes when it is not readily apparent. Additional elements needed for code assignment, which the coder should be able to determine from the record, are body system of organ affected and body system on which the procedure was performed. For example, patient underwent a colon resection and subsequently experienced a postoperative hemorrhage in the recovery room due to an accidental puncture of a small artery. As seen here, 2 codes will be assigned for these circumstances. We'll take a look at a few procedures that may be performed to give you some exposure to ICD-10 PCS codes and associated documentation requirements. ICD-10 PCS has specific definitions for excision and resection. A code for excision is used when only a portion or part of an organ or body part is taken. For example, removal of a colon polyp from the descending colon or removal of a portion of the transverse colon. Resection is taking all of a body part. For example, removal of the entire ascending colon would constitute a resection. This can be particularly problematic for the coder when your documentation is not precise or is ambiguous. So document precisely the anatomical site and whether a portion or the entire body part was removed. For example, colonoscopy with biopsy at 25 centimeters does not identify the anatomical location of the biopsy. You don't have to use the words excision and resection according to coding definitions. The coder will apply the definitions based on your documentation of what and how much was surgically removed. It is important to precisely document anatomical site for all procedures, not just excision and resection procedures. Take, for example, laparoscopic resection of a cecal polyp. Although the physician documented resection, the coder will assign a code for excision since only a portion of the body part is removed. Here you see the table the coder will use to construct the code for this procedure. The first 3 digits of the code come from here, indicating an excision procedure involving the gastrointestinal system. The next digit of the code captures the specific body part, in this case, the cecum. The approach of percutaneous endoscopic shows that the procedure was performed laparoscopically. No device indicates a device was not left in the body, as would be in the case for a PEG tube insertion. Finally, without a statement by you of biopsy or indication the procedure was performed for diagnostic purposes, the coder will select Z, no qualifier. The resulting code generated by the coder based on your documentation is 0DBH4ZZ. Excisional and non-excisional debridements are coded differently. Your documentation should clearly state either excisional or non-excisional. Excisional debridement involves surgical removal or cutting away of tissue. This is different from a procedure that is non-excisional or mechanical debridement, and which may simply involve brushing, scrubbing, and/or washing. In the case of an excisional debridement, your documentation should state the depth of the debridement or the deepest point from which the tissue was debrided. Was your procedure limited to the skin only, or was subcutaneous tissue also debrided? A single code is assigned based on the deepest layer debrided. Each tissue layer results in a different code. Take, for example, this abbreviated operative report. The physician did an excellent job documenting an excisional debridement, but there is contradiction in the documentation of the depth of the debridement. In the procedure description, the physician states excisional debridement was carried down to the muscle. However, the findings and technique do not support debridement of muscle. Only debridement down to the fascia is documented. Because debridement of fascia results in one code and debridement of muscle results in another, and only one code can be assigned, the coder must query the physician for clarification. ICD-10 requires more detailed descriptions in your documentation of anatomical site and aspects of a disease, condition, procedure, and circumstances of patient encounters. The information generated from ICD-10 codes will result in a more accurate picture of your patients, their severity of illness, risk of mortality, and the services rendered. This in turn will result in accurate public reporting on quality and outcomes. Should you have questions about documentation for a particular diagnosis or procedure, your hospital's clinical documentation improvement specialist should be your first stop. The coding staff in your Health Information Management Department is a valuable resource as well. Thanks for joining me, and have a great day.